when you have a supplement, A and B is still primary.
Right.
So when you go to a doctor's office and you just have A and B, how does it work?
You pay 20%
Okay.
of the bill.
Right. So 20% once Medicare puts their Medicare allowable charge on it. That's the same thing that's happening here. It's just they put a copay amount on it up to that copay, because if the 20% coinsurance is less, then you're not going to pay the full copay.
$10.
Gotcha.
That's why it's not really a true copay. It's a capped coinsurance.
Whichever is less.
That's what I mean.
You'd probably be better off, honestly, just telling everybody they have a $20 and a $50 copay, because the worst case scenario is that. The best case scenario, they don't charge it at all. The middle scenario is it's a percentage of that, or it's a portion of that, but not all the way up to that. As a mathematical example, if I have someone who is, goes to a specialist and the bill is at the Medicare allowable amount is $100, and they're paying 20% up to 20. That's an exact 20. If the Medicare allowable amount for that visit was 80, then they're going to pay 20% of 80, which is less than 20. Same thing at the ER. They go to the ER and somehow, which this is very rare because ER is expensive, you go to the ER, you don't get hospitalized, and you come out of there with a less than, I don't know what 20% of, let's say it's $180. Well, you're not going to pay the full 50 because it's going to be a percentage. But you don't really need to explain all that, because giving them the worst case scenario here is still not that bad. $20, $50. Right? Now, this excess charges is, a big hole there, because right now it's a 2 to 3% of the doctors in the country. I think Aetna said 4 at one time, but it's a very small percentage. In Tupelo, you got dermatology, and the dermatology center here does it. I think I might have seen one other specialist that charges excess charges in Tupelo. So it's very rare here. Certain areas of the country might be slightly higher. Like I've heard like Northwest Washington. And it still is not that big of a deal, because if it's a $100 charge, another 15% is $15, right? But if it's, somehow there's an excess charge applied to a procedure where they had a, I don't know, $20,000, $30,000, $40,000 charge, it could add up. So it's, anyway, the plan, it's a very low probability. This is when you get back to the probability risk matrix. Low probability that that's going to happen, but there's a moderate risk there if it does happen. So a lot of like e-brokers around the country are heavily pushing G still, just because of that. But if it wasn't for that, N would for sure make the sense.
The doctors and billing let the client know if they will be charged the next charge before the procedure.
I think that they're supposed to now, but whether they do is still up, it's just like they tell brokers what they're supposed to do years to come to fruition, because nobody's policing it effectively.
Technically, they're supposed to give them a sign something.
Think about it. All the rules they come out with us that they police, they're doing the same thing to doctors' offices. They come out with these rules, and I'm sure they try, but like, there's so many doctors' offices, way more doctors' offices than insurance agencies. So it's important too, since you guys are looking at multiple states now, to know about a thing called MOM states. In those states, MOM is Medicare Overcharge measure. There are some states that have enacted this Medicare Overcharge measure that prevents them from charging prevents providers in that state, it's a state mandate, from charging excess charges. So in those states, Plan N is just like an obvious win. But let's see. Now, interestingly too, sometimes you'll see the Plan N not be as competitive there, because they don't have that little outlet down the road to get out of little potential claims, right? Because they have to cover, the doctor's not going to charge. I guess they kind of do, because the doctor's not going to charge it. But normally those doctors are just recirculate. Money flows one way or the other, right? Anytime the government's like, you can't charge that much for that. Okay, we won't charge it there. We'll just charge it more over here for this. Because people aren't just like, well, guess I'll just close the doors, right? They'll figure out how to recirculate the profit. So the same thing in a state where there's a Medicare overcharge measure. If they can't charge excess charges and that's what they were doing, then they're just going to try to figure out another service that they're able to increase marginally their cost on somehow. So anyway, in doing that, the plans can go up. Medicare overcharge measure, I'm trying to see what states they are. This is not something like I know off the top of my head. I know Ohio is one of them, for instance. Let's see if we can get a state list. Here they are: Connecticut, Massachusetts, Minnesota, New York, Ohio, Pennsylvania, Rhode Island, and Vermont. So anyway, you're not going to memorize that. But if you talk to somebody in one of those states, then the plan in, you don't even have to go over excess charges. They can't charge them. So that's pretty neat. And if you know that in that state, no other agent they talk to will know it. Because agents just don't get that granular. So it'll make you sound smart. Oh, you're in Ohio. Well, that's a Medicare. That's your state has enacted and enforces the Medicare overcharge measure, meaning excess charges aren't a variable. Then you'll have some other e-broker that talks to that same person and says, well, you don't want plan in because there's excess charges. And I'll be like, well, Jared told me that there's a Medicare overcharge measure here. And then they'll be like, my brain hurts, doesn't compute. I don't know what he's talking. Well, I don't know what he's talking about. It's because you're stupid. You don't know shit about shit. All right, so if I'm explaining it, Plan G is super simple. So we've already gone over the difference between Medicare and Medicare with a supplement, Medicare Advantage, and you chose Medicare with a supplement because you want to be able to go to any doctor, but you want to look into that and see what the prices are like. So breaking down the two most popular plans, Plan G attaches to your A and B. You can still go to any doctor you want to. There's no provider network. There's no limitations. Doesn't matter what carrier we choose. That Plan G is going to latch onto your Medicare. Your claims are going to be automatically filed by Medicare to the supplement company. So if a doctor's office says we don't file with Aetna, they're wrong. Medicare files the claim to the supplement. It's an automatic filing system from Medicare to the supplement. So you don't have to worry about that. They don't have to be in a network. Occasionally you'll get somebody that says that. They'll have a Humana Plan G. We don't take Humana. Do you take Medicare? Well, yes. Then you take this. Occasionally you'll get that. You know, they're hiring new people at billing fronts and front desks as well. So Plan G is going to attach to your Part A and B. It's going to pay every single Part A and B cost sharing variable. The 20% coinsurance, the Part A deductible, hospital admissions, skilled nursing copays, for the copays for pints of blood, all of the out-of-pocket that you would normally pay without a supplement, it's going to pay except for the Part B deductible, which in 2024 is just $240. So you have a $240 medical out-of-pocket. Now, it's not going to cover drugs and dental and vision and that's what we'll cut into next. But that Plan G is very simple. Comes in and leaves only one little hole. It's going to cost you $240. First $240 of the year. Now, Plan N, very similar. It's going to cover all the big stuff too. Hospital copays, hospital deductible, 20% coinsurance, all of that big stuff, except again, that $240 deductible. And they're trying to give you a little bit more cost sharing so they can get your price down and keep your price lower over time. So if you go to the doctor, specialist, primary care, physical therapy, any of those, you're going to have a copay of up to $20. Can't be more than $20. If you go to the ER and you aren't hospitalized, you're going to have up to a $50 copay. Then you have excess charges. Now this is the variable that can be bigger, but currently isn't practiced and hasn't been, and there's actually some states that have a Medicare overcharge measure that prevent it from being practiced at all, and that's this excess charges where you can be billed in excess of what Medicare allows up to 15%. And you know, for $100 that's $15, but for $1,000 it's $150. So it can be an issue. So we still have a lot of people choosing Plan G to avoid that. Now I will tell you, it's less than, Aetna reports that it's less than 4% of providers in the country that practice this. If you're talking to somebody in Tupelo, you can say dermatology in Tupelo is the only one we're aware of that practices it in this market. And, you know, but there is some benefit here too. The premium starts off lower and historically it is much more stable. with many carriers being in the 0% year over year increase. So they're not adjusting their rates nearly as fast because they're passing on a little bit more of the cost sharing to you. Honestly, when explained like that, I still think a lot of them will choose Plan G. I mean, it's, if I was buying one of them, personally, I'd buy Plan G because I'll just eat the increases and not have to worry about it. And people that are old don't like worrying about shit. So, there's an argument to be made for all this. There's an argument to be made for Medicare Advantage. If you look at, if you took 100 people in the country randomly and you put them on the best Medicare Advantage plan in their area, and you took 100 people and you put them on a Plan G, and you came back at the end of their life and saw which ones were out of pocket, which group was out of pocket more, who do you think it would be? The med subs. They would have paid more. That's the way it is. Now, people want peace of mind, so they like to pay and just be done with it. So it's not a bad thing for supplements, because a few of those people on the Medicare Advantage plan would have been out way more than the people on the med subs. But as a group, so if somebody's playing the odds, Medicare Advantage is the better gamble. If I'm a better, But with med sup, I don't have to gamble, right? So that's how I'd explain it. I mean, once you get into the Medicare versus supplement choice, they're already choosing security, right? Plan G is just a little bit more secure.
What you need to do to build these plans.
Yeah. So what we call them is, the way they'll refer to them in those states. Let's back up. The reason these are a la carte states, when Medicare supplements were standardized in 1992, the original standardization, and then I think they were re-standardized or modernized in 2010. But when they created these plan letters, they were saying the Plan F does this, the Plan G does this, the Plan N, and occasionally a new one comes out, but it's standardized. 48 insurance commissioners agreed on that. 2 of them didn't. It was Wisconsin and Minnesota. But if you go to these states, you can refer to them as Plan F equivalent, Plan G equivalent, Plan N equivalent. How you build them is the way that Medicare supplements were built prior to 1992. You have riders that you combine together to supplement Medicare effectively. But each one will have a base. So the base Medicare supplement plan, because you can't have a plan of an insurance policy can't be 100% riders, because a rider has to be attached to a base. So in these states, they have a base, and then with that base, you can attach riders to cover different things. So a Part A deductible rider, a Part B deductible rider, a Part B excess charge rider, additional home health, and foreign travel. If you add all that, you have a Plan F. You want a Plan G? It's obviously the same stuff, except you've removed this Part B deduct. Wait, which one? Deductible. Yeah, Part B deductible. So just like, so when the Congress passed the MACRA Act in 2020 that outlawed Plan F from people, I say outlawed, made it where people couldn't get Plan F if they became eligible for Medicare after January 1st of 2020, which their Part A date. If their Part A became effective, this is why when you guys go through a Medicare supplement application, one of the first things they'll ask you is their Part A effective date. That's determining whether it can quote Plan F or it has to go Plan G as the top plan. But in these states, it's the same thing. They can't get a Part B deductible rider if their Part A date is after January 1st, 2020. So you go down to Plan G, because what Congress was trying to do when they did that is they said nobody can have first dollar coverage anymore. It's too expensive when people get used to being able to walk into the doctor and not pay anything. They have to have some cost sharing. That's why Plan G became the top plan. They said, well, at least if you have $240 in the game, you're not going to go for stupid shit. That was their thought process. I still think 240 is pretty low. It's not going to stop most people from going to the doctor. Maybe it would stop somebody. Most of the people would stop probably qualify for Medicaid and aren't paying anything anyway. Plan G, these riders, I do wonder if that additional home health rider has to be added to any of those, but just add it. I just don't know if I don't know. I'd have to look into that rider more. I'm pretty sure I read some of them that said the home health rider doesn't have to be added to any of them. Because I think the home health rider actually made it more like a Plan J, like the old plan back in the day. Anyway,
So in the portal, let's just say we're in the Aetna portal, we're writing a plan G, those riders are available to let you check as
yeah.
you're filling out the application.
Yeah, you can quote these in CSG, and when you quote them in CSG, it'll have all the riders. You can build out the plan and quote it, and that should help you like kind of identify who the top rate is that you want to quote. But what I would probably do on these is go over the first couple times you did it to that carrier and quote it within there and make sure the quotes align, just to make sure you're building it right on both sides. 'Cause I know Johnny had written one in Wisconsin or Minnesota the other day. I think somebody else did too. But I actually turned them off there for a little bit because people were getting confused. But now that we've gone over it, we're getting decent lead costs in those states. Because Munger just isn't doing his job up in Wisconsin right now. We actually picked up an agency, Joey Ryerson's in Wisconsin too. Yeah, there's a slight difference between Minnesota and Wisconsin too, but I don't know exactly what it is. It's not all that relevant because the quote tool will allow you to pick the riders.
But it's on our website. I just Googled Bobby Brock Insurance, Minnesota, and like it's the first link.
And these people, by the way, that you're talking to there, they don't know that their state is jacked up. You know what I mean? Like they don't know that. So when they'll talk to you, they're still asking for a Plan G, because all the marketing on the internet is Plan F, Plan G, Plan N. So they're thinking, I want a Plan G, And their friends in Wisconsin are telling them, I got a Plan G, because that was what was sold to them as a Plan G equivalent. So anyway, don't let that confuse you if you're talking to somebody.
Kidding me, man? This is the greatest conference all time. It's like nothing I've seen before. Coming back next year. The business is rapidly changing, and if you're not educating yourself, you're going to be left behind.
Great thing about Medicare Con and really any of these types of events, this one's so big, is you have all these people from chasing different pursuits in their business coming together and joining and sharing information. That's the best part of this. The conversations I've had with these guys right here, things that I wouldn't get just talking on the phone or anything like that. And the content here, it's been awesome. And Justin's done a great job, man.